Okay, so the next system we're going to talk about is cardiovascular. We really have to get the cardiovascular and respiratory systems together because circulation changes because our oxygenation location changes. So really quickly, let's look back at fetal circulation. Okay, fetal circulation. Blood comes in from the placenta. It is oxygenated. It comes to the umbilical vein, which goes to the liver, but there is a duct between the umbilical artery and the inferior vena cava called the ductus venosus. So most of the blood shunts over into the inferior vena cava. Comes into the right side of the heart. When that atrium contracts, some of the blood goes through the foramen ovale over into the left side of circulation. Here we are. Okay. Vena cava comes in. I see this drawing now. It's drawing straight to the foramen ovale. This should go up to vena cava, go into the right side of the heart. Okay, so go to the right side, right atrium, should go through the foramen ovale into the left atrium. Now, a little bit of this blood actually does go down into the right ventricle, not a whole lot of it. What does go into the right ventricle goes out through the pulmonary arteries. But remember, there's a connection between the pulmonary artery and the ductus arteriosus. So most of what's in the pulmonary artery actually goes into the aorta to go back into circulation. So only a tiny bit of blood is going to the lungs and then coming back. Most of the blood in the left side of the heart is actually coming through the foramen ovale, goes left atrium, left ventricle to the aorta, and then it's joined in the aorta by the blood coming over through the ductus arteriosus. So the reason this blood shunts from right to left, I need you to start thinking about shunts. The reason this blood shunts from right to left is because there's an opening for it to shunt through, and in this case, there's more than one. Okay, there's the foramen ovale, and there's the ductus arteriosus, and there's more pressure on one side of that than the other. There's a lot of pressure in the lungs because they're collapsed, and this is a smaller, these vessels are constricted, okay? So there's more pressure, and that forces more of the blood to go from the right atrium to the left atrium, and from the pulmonary artery to the aorta, okay? So remember that about fetal circulation, because those things are going to be important when we talk about the change. So at delivery, there are some anatomic and physiologic things that happen. The first breaths actually inflate the lungs, so that decreases the pressure somewhat. They also increase the oxygen level. Remember that the fetus operates with a lower concentration of oxygen. But after the baby is born, they take those breaths, and as the alveoli inflate, they get more oxygen in. And so the pulmonary vessels actually relax with greater oxygen. That increased oxygenation relaxes the pulmonary vessels. So that also causes the ductus arteriosus to constrict. So the pressure changes. There's decreased pressure going to the lungs, and the opening at the ductus arteriosus gets smaller, okay? At the same time, the cord is either clamped or it begins to dry, and so there's less space for blood to go through on the left side of circulation. And so that pressure increases. So remember, we have a right to left shunt in utero because there's more pressure going to the lungs and less pressure with the extra space that involves the placenta. So when we clamp off the placenta, we increase the pressure on the left side. And when the baby gets some oxygen in, that relaxes the vessels going to the lungs, and the lungs have begun to inflate. And so that decreases the pressure. So that means as the pressure equalizes, less blood is going through those openings, the foramen ovale and the ductus arteriosus. So because there's less blood going through them, the pressure's equalized. There's probably also some chemical role in closure of those, but the foramen ovale and the ductus arteriosus begin to close, okay? And they close over a few days to weeks. Prostaglandin levels seem to play a role in the closure of those, and there are actually some meds that can be given to promote closure of the ductus arteriosus if it doesn't close right away. If those pressures don't equalize, and if we have blood that still keeps moving through the openings, that delays the closure. So when we talk about complications in the newborn period, some of the things that can happen mean that those pressures don't equalize and there's still more pressure on one side or the other, and that can delay the closure. The ductus venosus also closes. Now, the ductus venosus and the ductus arteriosus actually become ligaments. The ductus arteriosus becomes this ligament between the great vessels, the great arteries, that actually helps stabilize them, okay? So after those openings close, and this begins to happen in the newborn period, but because it's not complete for a few days, we may have some intermittent changes in circulation. So now blood in the right atrium goes to the right ventricle, goes out to the lungs, picks up oxygen, comes back into the left atrium, goes to the left ventricle, goes through the aorta out to the body, returns through the inferior and superior vena cava. So now we have the circulation that you're used to with your adult patients. Now, while these openings are still in the process of closing, sometimes you may hear a murmur, and sometimes you may see a newborn with blue hands and feet. It's called acrocyanosis. It kind of comes and goes. It's not abnormal in those first few days, okay? So the heart rate should be between 120 to 160 beats per minute. In sleep, it may actually go down to 85 to 100, so it drops some in sleep. Variations are really common in the first half hour to hour. They need to be monitored and reevaluated. Blood pressure varies a lot by the size of the infant. 60 to 80 millimeters of mercury systolic, 40 to 50 diastolic. Blood pressure isn't always measured routinely unless they suspect a cardiac problem. Blood volume is about 80 to 100 milliliters per kilogram. The timing of cord clamping has a really significant influence on blood volume. So we used to clamp the cord just as soon as the baby was out, or the provider, the baby's out, clamp the cord, cut. And some research showed that babies tend to do better with delayed cord clamping. That transition tends to be smoother. They also tend to become anemic less often a little bit later on, but delayed cord clamping may increase jaundice, so be aware of that. So some signs of cardiovascular problems. These are things you need to be aware of. Persistent tachycardia or bradycardia. And remember, it can vary a little in the first half hour to hour, but if they stay tachycardic, that can be a problem. If they have bradycardia, it can be a problem. Pallor, the baby is pale. Central cyanosis, blue face or trunk. Jaundice in the first 24 hours. Jaundice can develop for several different reasons. And if the baby has jaundice in the first 24 hours, it is pathologic, okay? There is a physiologic jaundice that can develop after 24 hours, but if it's in the first 24 hours, something is wrong and it must be evaluated. Heart murmurs should always be evaluated. Most of them are benign. And again, you may hear some murmurs just while we're waiting for those openings to close, but they should always be reported so they can be evaluated. But the absence of a murmur also doesn't mean that there's no defect. There are a lot of serious congenital defects with no murmur. And most murmurs are actually benign. So it's something that should be evaluated. It's not something to get the parents worried about. All right. So in the next section, we're going to talk about the hematopoietic system making blood cells.